Good morning. Good morning, everybody. First of all, I would like to thank the organizer of Presbymania for inviting me to participate in this interesting meeting. In the next few minutes, I would like to talk about presbylasis. Is the presbylasis a good option for all the Presby patients? In my opinion, no. We have a limit. With my platform, we have a very interesting limit. I speak with the limit with the Waylight Allegretto platform. After February 2010, I have the opportunity to operate more than 500 patients. Today, I have the possibility to present you the result that we have analyzed our first 150 patients with more than 20 months of follow-up. You know, our blade cornea had Q greater 0, spherical cornea equals 0, and prolate cornea less than 0. In my opinion, normally we present the conclusion at the end, but I'm today going to start with them. In my opinion, the ideal presbylasis patient profile is a patient with between 14 and 60 years old, without cataract, with density of the crystalline less than 20, for example with Panchacam platform, with ACD greater than 2.50. I don't know now exactly why, but the results are this. White to white more than 11.5, dynamic pupil between 4 and 6 millimeters, mesopic dynamic pupil, curva binocularity, the surgery keratometry is between 39 and 47 dioptria, hyperopia less plus 450, myopia maybe between -4, -450, in my experience, astigmatism less 1.50. We use the Waylight Allegretto FCAT software, and we propose you to change, to modify the Q value in myopia between 0 to -1, modifying the hyperopic shift with the Cernicke. In hyperopia patients between -0.25 to normally -0.8, in some cases -0.6, modifying to the hyperopic shift with the Cernicke. This is my limit. First case, a medical doctor, 52 years old, the right eye, the refraction plus 325 hyperopia, plus 135 astigmatism, no dominant eye. The left eye plus 225, only a little astigmatism, dominant eye. Okay. The surgery was in April 2010. It's very interesting. You can see the difference between the correction and the refraction plus 325, decoration plus 425, the same astigmatism, but using the Cernique, we can modify the hyperopic shift. Spherical aberration modification increases, do you know, depth of focus, but the focus is very similar and the ablation is very similar between the spheric treatment with the optimized treatment. You can see now the dominant eye plus 225 is the same. You can see the correction plus 225, the refraction plus 225, and the correction plus 350. The Q target minus 0.8, but the focus is very, very similar, and the ablation is very, very similar. You can see the result 2 years after the procedure. I corrected visual acuity 1.2 J2, and he doesn't need reading glasses at any time. In low myopia, the analysis of the result has been much more satisfactory than I expected. You can see a 43 years old patient, right eye minus 150, a little astigmatism, left eye similar refraction, but it's very, very, for the first case, you need to know that the correction and the refraction is very different. You can see that the refraction minus 150, but when you modify the Cernique, the correction will be plus 0.40. In the first person, it's very complicated. I understand this. You can work inside the Cernique coefficient. The C4 is very similar in the FCAT treatment and with the optimized treatment. In this case, in the left eye, you can see the refraction minus 175 and the correction with the Allegretto 0, and only we correct only 0.50 astigmatism, but the ablation and the focus is similar. You can look, you can see. I use in some cases optical zone 6.50 because in Canary Island we have a typical eye, thick corneas, a big pupil. In some cases we need to use 6.50 optical zone. You can see the 2 years after the procedure, the corrected visual acuity 2020 J1, J2. For me, the limit in myopia is between -4, -450. This is very interesting case, 42 years old, -450 in the right. In the left, you can see now the difference with the modification. After the modification in Cernique, the refraction that we operate with the software is only -245 and the correction was -450. The optical zone to 6.50. Here the difference is 1 dioptria and 50 between the refraction and the correction. The Q target in all cases in myopia I use -1, like my different speaker before me, and the result binocular and corrected visual acuity 1.2 J1. In my opinion, but only I have in my 500 patients, only 2 people with pseudophakia. In my experience, not a good option, a good result. In both cases, the patient need to use glasses after the procedure for reading. These years, after 500, I recommend don't begin with the emetropic patient with this technology in the first moment. 2 years after my first patient, I begin with emetropic cases. In this moment, I have only 2 emetropic patients with presbylacy, and the result was very good. But it's necessary to the election is necessary, is very for conclusion, this is not a single and definitive technique, so the ophthalmologist must know then all in depth to give appropriate guidance to the patient. We have the corneal surgeon, we have another procedure, for example, the flexi-view, for example, the acufocus. The patient must have adequate motivation and understand the expected benefit and the inherent limitation of the proposed surgery. Thank you for the Presbymania group. Thank you for listening.
Thank you very much.